is Danielle Straukus. I'm an RN. I have a bachelor's degree that I got from Rutgers, New Jersey. I also have my CCRN. Been a critical care nurse for almost 22 years now.
And tell us, I understand that you've been working very diligently in a COVID ICU in a major city in America. Tell us a little bit about that experience and what it's been like for you.
Well, for me, it wasn't really that bad. I know it's going to sound horrible, but like I was so used to working in trauma centers in very like in Newark, New Jersey, Camden, where there was it was just a lot of epidemics there: HIV, hepatitis, tuberculosis. So this really didn't actually rattle my cage. But there were nurses that are terrified to this day. They cry, they don't want to go in. So usually I'll volunteer for them. I don't really, I know it was scary in April where people were dying a lot. My problem actually held more with that you forgot about the people that were in the ICU, the patients that were in the regular ICUs, neurosurgery ICU, trauma ICU, that there were people that were dying there alone too. That because of COVID, that nobody was allowed in the hospital, no families, no visitors, no nothing. People forgot that it wasn't just COVID patients that were dying alone. It was every patient that was dying alone in the hospital.
And I guess, what's that like? I mean, it was so unusual, wasn't it, to see all these patients dying and to really be by yourself?
I don't think anybody should ever die alone, ever. And especially during COVID, because now people are scared, they're terrified. And all they knew before that they were intubated was that people that became intubated were going to die anyway. So I can't imagine what it was like for them. What I did was I was always with my patients, even to this day. It doesn't matter if they have COVID, whether they had a major stroke. To me, it's like you have to do the best you can for these people. Nobody wants to die alone. I think my mother taught me that when I was 5. She's also a nurse. She said the worst thing I fear is to die alone. So I think it gauged my whole nursing career, that I make it a point that, you know what, no matter who they are, whether it was AIDS, whether it was a stroke, whether it was a car accident, you never let somebody die alone.
And I know you had shared with me how difficult some of these young nurses had of dealing with patients, like so many dying on a shift, and that you became their mentor. Share with us what that was like.
Well, I think it's still people, you know, when nurses first come into this field, I don't think they usually actually understand the full range of what you're going to deal with. Even to this day, it isn't even COVID, but COVID, they saw it on a large spectrum of how many people were going to die at one time. But these nurses, they would just cry. And there was my friend Sarah, who's been a nurse probably longer than me, just broke down. She said, I can't take it. I just can't watch these people die every day. And there was a lot of nurses that couldn't even handle it. I think the reason we're so short right now is because a lot of nurses quit. They just couldn't handle the pressure of going in there, not knowing if you're going to take it home, you know, to watch people die. I even told my CNO, because she asked how it's going. I said, you know, it's hard. I said, I'm not speaking for everybody, but I'm going to tell you what it feels like for me. I said, you go in there and you know that you can't get into these rooms as fast as any other ICU, because now you have to like literally spend 10 minutes getting all geared up to go in there with all your PPE. And then you get in there, I said, and you leave your shift knowing that you didn't do anything close to what you should have done or could have done for that patient. So when you go to sleep at night, you're up every hour because your brain doesn't want to sleep, because you know that you left things undone and you wonder what you could have done better. I said, this is what's ruining this profession. It's killing us, because I said, nobody realizes the toll it takes on nurses emotionally, because you know what, you're not supposed to say that it's eating you up or you have problems. And I said yesterday, I said, this is why nurses, our profession alone, has one of the highest rates of alcoholism, drug addiction, and divorce. Because you're taught early in nursing school, you're not supposed to vent. You're supposed to be able to hold it in. You're supposed to be the rock for that person, the patient. And a lot of nurses don't have that in them. And the ones that do almost scare me, because when they have it too much, do they like detach themselves from humanity at that point? So I think it's a little hard to watch these nurses, especially the younger ones.
So has the nurse to patient ratio changed at all where you're working?
Oh, I have 3 ICU patients every single day. That's whether you're in COVID, whether you're in a regular ICU, because a lot of the medical ICU nurses have quit. because they don't want to deal with the COVID. So then we're the ones that are staffing our COVID units. So now either doesn't matter which ICU you're in, you're going to work short. And that's on a consistent basis.
Wow. So, I mean, how can you, gown and glove and do all your PPE and go between 3 patients and manage their care and, their IVs, their vents, their meds, their emotional needs, their personal care?
How do you even come close to meeting an emotional need when you have a PAPR on your head and your patient can't even understand what you're saying? So when they just want to talk and vent or even be able to say anything to you, they don't even hear you. They can't even talk to you because you have this thing on. And then God forbid, the thing that would bother me the most of these PAPRs. So we clean them and we leave the room. Well, okay, but now I'm inhaling all the chemicals, the CHG that you've just wiped down all these PAPRs with. So in 20 years, do I have to worry about having some type of lung cancer because of it? Sometimes I think that every day that I go in there, I'd rather have COVID than actually be exposed to all the chemicals. And I started asking a lot of the nurses that I work with, and they said, you know what, I feel the same way. I'd almost rather you expose me to it than me have to worry about this somewhere down the line.
So Danielle, excuse my ignorance, but I don't know what a PAPR is.
So a PAPR is almost like a respiratory. It's got an oxygen it's positive pressure that'll attach to an actual hood that goes over your head. Well, every time you go into that room, you have to gown it up. It's electric. So literally it's just positive air pressure pushing through the mask. But when you leave, you actually have to wipe it down with a chemical called CHG, which is great. But we started realizing we were smelling it when we were when we regowned and put our PAPRs back on. You could smell the CHG coming through your mask. And I said to even my manager one day, I said, how healthy is this? We're breathing in these chemicals. So I think that's a big fear for the rest of us that use these. Really, honestly, I'd rather be exposed to COVID than to actually go through that.
Wow. So tell me a little bit about, you've cared for all these different patients. Share with us, one of your heartfelt stories about a patient or an experience that's really touched your heart.
Oh, almost 22 years, there's too many to count. I would say, I guess, even just probably one about 2 weeks ago was a good one. There was a man it's a neurosurgery ICU patient who had a big bleed. His family couldn't be there because there was no visitors allowed. But he came in and he had a pretty significant bleed in his head. They took him to surgery, and I got him the next day. And he was fine, but they noticed that his bleed was getting a little bit bigger. The surgeon just did not want to take him back to the OR. So I sent to my patient that night, and me and him he was from the Northeast, so me and him were the best of friends. And I said to him, listen to me. Tonight when I leave, you're going to tell this nurse, because I know she's not going to answer you. You're going to tell her if something's different. If something doesn't feel right, you need to tell her because something isn't right. So the next morning, the nurse said to me, whatever you said to him at 2 or 3 o'clock in the morning, he called me and he said, something's not right. So at 7 o'clock in the morning when I was there and the neurosurgeon came in, he went in the room and he said, but he still follows. And I said, he's not right. He knows he's not right. Something's not right. So the patient looked at him. He goes, she's telling you I'm not right. So he's like, they want me to take him back to the OR. And I said, oh, you are? Good. That's great. I already got all his papers ready for you. So he said, well, I guess, Danielle, now I'm taking him back to the OR. So he goes, well, maybe we'll get him back at 12. And I said, well, I guess I just have to keep him in one piece until 12. And he goes, okay, 9:30. So now I turn around, my patient goes, he comes back and he's on a ventilator. And I beg him just to don't extubate yourself tonight. We're going to tomorrow. I promise. They just wanted him for one night. Just promise. And all night long, I didn't have to keep this man into it. I didn't have to restrain him. I didn't have to sedate him. He was just amazing, following commands. So the next morning, the surgeon comes in and he said, we were thinking about keeping that tube. And I said, you can't do that. You absolutely can't do that. I promised him, you promised him it's one night. He did good all night long. He said, you did everything you asked him to. You have to take that tube out. So he goes, okay. So even the intensivist, she goes, Danielle, I don't know what you do, but you get him to listen. I said, there's nobody to speak up for my patient. Who's going to? So then we ended up getting him extubated. Do you know I had that man walking? After he got extubated, he was walking around and the physical therapist looks at him and she goes, Danielle saved your life. He goes, I know she did. She's like part of my family now. So then I was off for 2-3 days. And I said, I came back and I didn't see his name. And I was devastated. And I said, oh my God, did I push too hard? Did I really did I do something that this guy probably rebled? I don't see him on the list. Did he die? And so I turned around and I asked one of the chargers, and he goes, oh no, he did great. He was discharged. They couldn't even believe how well he did. So I literally, it's like one person that you actually make a difference by standing up and not being afraid to say something to a surgeon. That guy got to go home to his 4 daughters and his wife. And how often do you see those things happen? So the intensivist laughs at me all the time. She says, you're never afraid to fight with anybody. And I said, no. She goes, but you did. You actually saved his life. So that one was a couple weeks ago. I just think that nurses need to be a little less afraid to speak up. I think that we're taught that, you're supposed to follow what a doctor tells you. It's always what they say, and never think outside of the box. And I said, the worst thing that they're going to tell you is no. Well, okay, then explain to me why. Tell me why it's no, and then I'll be okay with it. It's got to be something I can sleep with at night, something that my conscience will let me sleep with. So if I don't speak up and something happens to my patient, that falls on me. Not because I just didn't say anything. And it's just one of those things that I don't think that we teach nurses.
So let me ask you this. Do you think some of that can be taught, which I suspect some of it can, but do you feel that some of it also comes with, the experience of years that you kind of have, your critical thinking skills, and your assessment skills, but isn't there also sort of an intuitive expertise that you develop as a nurse over time that you can almost kind of foretell a pathway of a patient so that you can best guide them and help them?
Well, I think you need the experience before you go standing up to a neurosurgeon. I think you need some experience. You need to have an idea of what your thought process is behind that, because if not, he'll chew you up and spit you out, and then you'll lose all credibility. So what I tell all the new nurses is, because I'm like, you know what? Yeah, most of this is my personality that I'm just going to fly by the seat of my pants. But it's the experience that comes with it. So I always tell them, I'm like, here's the thing. If you're not sure, just come ask me. We'll figure it out. And that's what I do. I have my baby birds. They come and ask me, okay, well, what is it that you're not sure about? And then when I tell them, then they go. And I said, now go talk to Dr. So-and-so. Go ask this one. Because you have to ask, because they are never going to give you the respect you deserve until you stand up, you bring your part to the table. That's all the doctor wants to know. Look, they'll listen to you, they'll entertain you. 1 in a million that are going to sit there and not listen to you anyway. But I found 90% of all doctors and surgeons, if you have a valid reason and complaint, they'll listen to you, and then half of them will entertain you. I will ask the doctor, this is what I see, this is what I observe. Can we try this? And even if they think that it's not going to work, half the time they'll let me do it just because okay, see, it didn't help, or it did help, but we did try it your way. And I think nurses need to be able to stand up for their patients and be able to say, you know what, I'm not going to get fired over this. And I'm not going to lose my job over this. The doctor's not going to turn around and scream at me over this, because it's not the 1950s anymore. Doctors are not supposed to be screaming at you, period. So it's been, but I mean, it's actually really good. I actually like working with younger nurses because I like molding them versus your older nurses that are already set in their ways, and they're just, half of them that I think are so burnt out they don't even care.
Wow. So if you were to say somebody was considering, what do I want to be when I grow up? Or somebody that's, in their 30s or 40s contemplating a career change, a second career in life, what could you share with them about why they should consider nursing?
This is the part you may not agree with me. I'm very honest about nursing. It's either for you or it's not for you. Don't go in it thinking that it's prestigious or there's something because you make good money, because either you have it or you don't. I tell them it's like being pregnant. Either you are or you're not. There's no in between with it. There's no halfway nurse that says, you know what, some days I like it, some days I don't. It's either something that's in you to do because it's hard, it's backbreaking, and there are days that you want to quit. But if it's something that you love, you don't lose that kind of love for it. So nurses, I always tell them, make sure this is something that's for you. My own daughter didn't want to be a nurse. She said, I don't have that part in me.
So do you feel that nursing then is more of a calling than just, a career that you can make good money is what it sounds like? It's something that it's a calling?
Sure. I would be, if it wasn't a calling, I'd be doing something else that made a lot more money than this, because if people think that we make a lot of money for what we do, we don't. The price that we pay emotionally, physically, I said, I'm in my 40s and I walk like a little hunched over little man. That's because I started when I was 17 years old as a nurse's aide in a nursing home. So either it did, and that's what it was. I started from there to figure out, was this really for me, or did I just think it was just a great job at the time? It has to be something that's in your heart, or you just won't survive it. That's why you see so many nurses going into a nurse practitioner, or they go out of bedside, because they know that that's not what they want to do. And then you see these nurses that are bedside that are 50, 60 years old because that's just what they love doing.
And I guess circle back to your COVID experiences again. I know that when you and I spoke initially that you were upset by what you were seeing with the COVID patients, but you were also upset about the people who were left out on the streets and how this pandemic has, affected so many people that are left jobless and living homeless on the streets.
You know what? And then ironically, you should say that, because yesterday, the past 4 days, I have a patient that's just like that. And it kills me because this guy is 58, 59 years old. He was in a shelter. And when COVID hit, they kicked him out of the shelter because of the social distancing. He was on the street. He had a stroke and nobody noticed for 2 to 3 days. That he was dragging himself on his right leg, that he has nothing but road rash on that side because he couldn't even get help. So explain to me how we're a better nation because of that. How do I tell this guy, now we could have done something preventative? Or did you end up having a stroke because of the stress that was behind that of being homeless? That's one of the things, it'll just keep you up every single night. Like, how do you explain this to me to tell me that this is right? This is better because of COVID. How do you tell this man that his life, what's left of it? Now you're paralyzed on one side completely. And now I can't even get you into a rehab because of all this.
So what happens to patients like that then when they're ready to be discharged?
They're actually, now it's literally depending on the hospital, like we'll end up harboring him for a while until we can actually get him placed. But that's how effective that is that for a stroke patient. Stroke patients need like aggressive therapy. They need to be in rehabs. They need to be up and ambulating, moving. They shouldn't be like stuck in a bed in a hospital room, because number one, you won't have the nurses or the therapists to be able to actually give him what he needs. And he'll just become atrophied, and what little use he has is going to be gone anyway. So it's hard to watch it. It's actually heartbreaking.
So how do you think nurses handle that when they see and recognize that, but the grace of God could be, a family member of mine that this happens to, and the lack of healthcare just because of the impact of the pandemic, the impact of the negative economy, everything closing down?
Well, I think it's taken a big toll on nurses. Like yesterday, I was talking to another friend of mine. They're so burnt out. We're so fried because you know what it is? We're overworked, which means that we're giving less to our patients, which means that we carry more of it at home. And it takes its toll. I've never seen nurses call out as much as I have in the last 3 months. Ones that are scared to go to COVID, ones that are working so much every day, overworked, and they're just tired. So I think, and I'd like to think that that's pretty much nationwide, because I can't imagine our system's the only one that's doing it. We have close to 20,000 out here, but our hospitalization isn't close to anything compared to the rest of the country. So I can't imagine what the Northeast is going through with their nurses or the beating they're taking.
So my biggest concern, I think I shared with you, is that COVID is we were already always talking about a shortage of nurses before this pandemic. And now I think that at the end of this pandemic, because of the emotional toll and the physical toll, that we're going to be a nation without, essential healthcare professionals, nurses. And so that's why I think that our Nightingale Project is so incredibly valuable and important right now, because being able to tell stories of making a difference in people's lives, finding a calling that has meaning and value in today's world, can maybe, enlighten others as to, what this profession really is all about and what it means. So many people say, I don't want to be a nurse. I can't deal with blood and guts. It's like, it's not about blood and guts always. It's about it's about caring and loving people. It's about empathy and care and compassion. And if that's what's in your heart and your head, this might be a really valid path for you. And it's not an easy path. And it's, as you said, it's not for everybody, but we all need that angel at our bedside, that person that advocates for us, that person that can just hold our hand, if nothing else, when you're dying and going other places in this world and other world. It's just such a gift, I guess, that nurses have to share. And you can't say that about other professions.
My biggest thing about nursing is that I don't think that we can even come close to the resources that we deserve. You have firemen, you have policemen, even the garbage men have better retirement system than nurses. And I hate to tell the world that, but it's true. So if you're in it, it's because you really love this. But I'm sorry, I think that nurses need it. The nurses that go into the subspecialties, I even said it to my boss the other day, you don't educate them enough. You don't give them the resources they need. There's nothing to make them want to stay. Give them a reason to stay in this profession. Make them feel that they make a contribution, and that if something happens, that they're not just a number. Because that's majority of what nurses think. I'm dispensable. Everybody's dispensable. I walk out of here, they won't remember my name in 5 minutes. So what's going to make them want to stay? I'm not saying a better pension or anything, but give us a real. I mean, schooling, we pay almost out of pocket for our school. But you force us to want to, in New Jersey, you had till 2020 to have a bachelor's degree. How do you say that without actually helping us do it? Now, you want us there because we're one of the largest professions in the world, but you're not helping us. Give them a reason to want to be at the bedside. Don't make it impossible. Well, if you don't have a bachelor's, you're not going to be working. Well, then they were like, well, that's fine. I'll go right from my master's and go teach, and I don't have to deal with all this anyway. So I think that's my biggest gripe with nursing right now.
No, you've really accidentally hit on some key points that we're trying to put together to really help bring attention and help nurses with different financial planning, and have other entities that can help nurses with financial planning and financial stability, as they age. So that's just, you accidentally shared that with us. And I think that too is just so important. I agree, nurses need more support in what they do. We need more people that can be at the bedside and be with us, and not just consider them a number or a commodity.
Well, I think half the nurses, especially the ones that'll go above and beyond, half of them are afraid because they feel like if they make a mistake, nobody will back them. The other half will be afraid to do it because they're not really sure of something, and they're not afraid to ask somebody. The culture itself in nursing has to change. That's a big part of it also. You have to, I know that we have that running joke that nurses eat their young. I get that, but that's horrible. Me, I train every single one of them, because you know what? One day one of them is going to be my nurse. And then either I teach them the right way, or I suffer the consequences when I'm older. And it's just a simple way. I like like I said, I like the younger nurses because they want to learn. Every one of them wants to learn. And they're so scared to ask somebody, and they're so scared to make a mistake because we're so quick to be like a mother and chastise these nurses that they'll never go out of their way again. So that's what I mean by resources. I said the other day in my specialty, I said, I think nurses, these newer nurses, they need a shadow. Somebody that they trust, somebody that's willing to turn around and have the same schedule with them. So my boss said, but there's no money in it. I wouldn't care that there was no money in it. One of these nurses needs help, and literally, I have one that it's like my pseudo shadow, because he comes, we have almost the same schedule. I teach him everything. And he said, you can't leave me until I leave. But it was the point, because he's not afraid to come ask me. And that's the way it's supposed to be. You're not supposed to be afraid to do something in nursing. So I think a lot of it, that's what I mean, there's the resources, financial resources, emotional resources. Even when you know that one of your nurses is struggling, I've never seen somebody pull them aside and say, what's going on? Are you okay? I literally pull them off the floor. I'm like, I'll watch your patients, go in the back, have your moment. Don't ever let them see you cry, because they'll never let you let them down. But then come tell me what's going on. But it's a hard thing for other nurses to adapt to, because they're so quick to blame you for something. And I watch it every single day. They love to oh, she didn't do this, she didn't do that. Or I wish we could just change the culture of the way we think, instead of always criticizing. more like embrace, endorse, like help your coworkers. Like, I just think it's a terrible thing to do. Like, we beat each other down instead of lifting each other up. And I don't know if it's just something that has gone through time, because it's just over and over and over. I've seen it go on for the past few decades. But I don't think it's good. I don't think that's what's going to have nursing contribute to nurses, new nurses coming on board. Because that's what first thing, if I saw it today, I'd be like, why would I want to go there? Who would want to deal with that stress every day? Walking on eggshells, wondering every day, if I make one little mistake, am I being called in that office? Instead of embracing your like the new nurses, whether they're old or young, it shouldn't be a culture where you're penalized. It should be like taught, educated. Why is it wrong? It's because of this, this, and that. Not you're just wrong, period. So that's what I mean about some extra resources. I don't think we have enough educational resources. Our education system in my hospital is on a computer. Here, do your health streams. Well, what does that teach me? Sure, I've been a nurse for almost 22 years, and I know that. But what does that teach somebody else? Oh, how to click next and go through your health streams. You don't really know if they know what they're doing. You don't know if they have any questions. The computer's not going to answer their questions. So that's my problem with all of it, with nursing, the future of nursing on it.
So how do you think we can change that culture? Is it through education? Is it through identifying nurses in hospital systems to be the type of mentor like you are?
I think it's all of it. I think it's another one is that we should actually change the way we think. Like, we never sit there and embrace it and lift each other up. I've never seen it where we sit there and like praise the other one. Like me, I'm quick to say something, like, I don't even care if I like a woman's shirt in the store. I tell them I compliment them. But I think it's one of those things that we need to learn how to pat each other on the back instead of being so quick to knock the other one down. And I think that comes from the top.
Yep. I agree. I totally agree.
When COVID hit, I'm going to tell you, I had more respect for, I think it was the Princess of Sweden. I saw it on in the news one day, and I said, because she was in scrubs, and she said, you know what, I don't know anything about healthcare, but she was helping pass out trays because she was in the hospital. And I said, that woman leads by example. She was there. It didn't matter. Like, it would have been nice, even with COVID, if you saw some of your management in there helping out, even doing a simple task, just so that these nurses knew that they weren't alone. To me, that would have been a start. It would have literally boosted the morale 1,000 times, instead of just leaving them like, they don't care, they'll throw it. And that's what there was a meme online. It said, telling us that we're essential is essentially just telling us that we're just, we're dispensable. Because that was the way the nurses felt. That it was sacrificial. That was it, not disposable, sacrificial. And I said, that's the way most nurses felt, is that we were just, it was okay. They didn't care what happened to us. If we got sick they'll just replace us with somebody else. Maybe that's really not how all of them felt, but that's the way it'll come across, because you never see one of them in there trying to help out. So I think that would be a big part of keeping nurses, promoting nursing. They don't feel like they're alone. Like, you feel like you're on a one-man island when you go in there. And if you don't finish or something happens, it's you that's responsible. Not we that's responsible, you.
That's so unfortunately true. Working now as an employee within a hospital, and you also know that as being true working as a temporary staffing nurse. I mean, it's always looking for the sacrificial lamb, and it's usually the nurse. And you're right, it's not about learning and correcting and teaching, but there's such a fear of, fear of lawsuits, fear of all kinds of things that just really take away the care, the compassion, the empathy that nurses start with, and somehow they end up at certain points in their careers feeling kind of cold and left behind, and that's not who nurses are.
I'll give you a perfect example. Last week, a nurse, she's a newer nurse. She left the unit, hysterical crying. Now, I didn't have a problem with what she did. It was a learning experience. I said that was the reason I brought up, we don't have enough education for these nurses, especially with specialties. So instead of the nurse manager called her, said she wanted to talk to her. And instead of saying, okay, well, What is it that you feel like you're not getting, or that you were missing? Or what do you suggest? Do we turn around and put you with somebody? Instead, she turned around and basically told her that it was because if something happens to that patient, that basically it was her fault. And it wasn't true. She made a couple mistakes, but it wasn't something that was detrimental to this man's. It wasn't the fact that the surgeon had waited 24 hours to take the guy to the OR. Let's not just say where it really should have, the blame should have placed. Let's blame the nurse, who all she just simply did was the guy self-extubated himself. And she forgot, she didn't turn off the drip because she thought the drip would actually help his brain a little bit better. So now you have a nurse who's completely ready to leave the nursing field because she said, I just can't do this anymore. When it could have had such a different outcome. That's what I mean about, like, it's just horrible, the things we do to our nurses.
No, that's so true. We'll circle back to patients. Are there other stories that you can share about patients that, that really touched your heart personally, that either made you cry or sad or happy?
Probably the one that probably made me cry the most was about 10 years ago. It was a patient in neuro. I'm sure it's still a super comprehensive neuro hospital in New Jersey. The patient was being flown in, and the surgeon had called me and he said, she's basically gonna die. We're just bringing her here so, the family can turn around and say goodbye. And I said, okay. So I got the patient. And I always know, especially with neuro patients, I think it's because of my love for it. I always know when there's something still in them. And sure enough, she was still there, and she'd start opening her eyes. And that whole day, the one word she could say is Danielle. And the doctors were laughing. They're like, of all people, because you could just hear her yell. But I was able to get her family and get them to come in. And her daughter, Erin, said to me, she said, well, I don't know what to do. And I said, well, I think that was what God meant, is that she's here to tell you. This is what because she told them, I don't want to be intubated. I don't want to be trached. I don't want to be pegged. I don't want anything. I said, you got the gift that most people didn't. You got to say goodbye. And so the woman did really good. And here's the part that made me cry. So her granddaughter comes in, who's 8 months pregnant. And my patient is just holding her belly with her hand. The one hand that works. So me and Dr. Devine are crying hysterical because we thought it was the prettiest, like the most beautiful thing. Well, the woman ended up stroking out the next day and died. And I said, at least she got the chance to say goodbye. Like, she got more than most people ever do. And what happened was the family was so happy and so grateful about what happened that they donated money into the hospital in my name. Just to say thank you. And I said, I'm like, wonderful. Nobody ever gets that chance. So of course they got the picture of her holding her granddaughter's baby, her baby bump. That was probably the one that still gets me.
Made me cry too.
10 years still makes me cry. Because I remember like it was yesterday. Such an amazing story. Because you know what? You just know that even though your job is to be there, there's still something else more out there. And there's a reason that things happen. My sister always says, God knows exactly what he does when he gives you the patients you get.
That's true. I want you to be my nurse. When I have my major stroke, which I probably will, I've already had 3 lacunar strokes, so that's how I'm going to ultimately die.
I'll know when I get the note. Pat says that you have to go fly out there to go make sure that they don't do anything.
Yep. Well, I really appreciate your time, Danielle, and I know that you're incredibly busy, but our interview is just so helpful, and there's so many pieces of it that I'm sure we'll be able to use. And in case, I haven't talked to you for a while, so just so you know, the progression of where we are with everything is we're going to have a mobile app site up under Nightingale 2030 in August. So we'll be editing parts of these interviews to post on each month. So I'll let you know when you're going to be featured, because I'm sure you will be. And then in the first quarter of next year, we hope to have our documentary on Florence Nightingale up with interviews such as this on part of it.
If any part of it helps nurses, just in a small way, it would be worth it.
Well, I think you did a great job at sharing what the heart of a nurse looks like and feels like. And And that's what's so important to convey as well. And so many of your comments, you know, will help us because we're also talking to a lot of different sponsors for the Nightingale project. And I think you touched on things that will be able to go out and get sponsors that can help do various parts of this. I'm going to send you, since I have your email, the what the Nightingale Resilience Fund looks like, because you'll see what we're looking to achieve, and you've touched on so many of the topics, and there'll probably be a contributor with your name on it again, having heard you, and I thank you from the bottom of my heart. I really do.
I think the way we change our culture is we have these conversations, whether they're good, bad, or ugly, but they're conversations that have to be had.
Yeah. And you speak for so many that don't have that voice or aren't willing to voice it, let's put it that way, for fear of so many different things. So I appreciate your sharing your voice and your thoughts, because I think lots of nurses feel that way but can't verbalize it. And the other thing, you know, I'll share with you too, is that I'm also working with a nurse out in San Francisco, and she, like you, she's a pediatric ICU nurse, but she started a community of nurses, and it's about helping support nurses' mental health and well-being and sense of self. And, you know, she would be just dynamite for you to talk to at some point, because she's engaging nurses within hospitals to do this sense of community. I don't know enough about it yet, but she's putting it together, and she's just joined our advisory board. And I think what she's doing to help nurses kind of ties right into what you're talking about as well.
She might be a good person to start a project with, because I always believe that nurses should have their own PBA like cops do. Sure, we have a board of nursing, but our board of nursing is just like internal affairs. They're not really there to help us. They're there to interrogate. And if we had our own backing, somebody that's going to be there for us, we're over 3 million. The things that we could do to help each other would be outstanding.
Oh, exactly. And there's like almost 30 million around the world.
Right.
And we all have the same issues no matter where in the world you practice nursing. That's why nurses leave one country to come to another country to work and experience, and then you hear the same stories. They don't really change.
Well, the reason that I had thought of that idea was, my sister calls it my Shark Tank idea. The reason I had thought of it, I said, because you know what? Management's never really going to change. It's never going to, and I always say you lead by example. So if we don't help each other, how do we expect anybody else to do it? So if we had our own group that actually helps each other, sure, you contribute a little bit, but it's to your own. So when somebody has a mental breakdown, instead of them turning around and waiting till they're literally at the bottom or literally ready to commit suicide, how about you get them some help first? Somebody intervenes and says, look, because if they had a safe space that they could call somebody and say, look, this is what's going on. Nurses understand each other. We already know. It's not like we're going to blow each other off and say, oh, it'll go away. We know exactly what you're going through. And I think that's what we need. We need our own group to support each other.
Yep, you're absolutely right on. Absolutely. Well, I thank you. I've taken enough of your time. It's are you working this evening again, or?
No. Actually, I'm back on days, thank God. But I'm off for 2 days, and then I'll be back.
All right. Well, thank you again. I'm going to let you go enjoy the rest of your day, and a big hug to you. I really, really appreciate it. You're such a special lady all the way around. And
thanks, Pat.